Good evening and welcome to the End of Life Planning webinar. Tonight, we're fortunate to have two very, very talented and knowledgeable speakers in the area of hospice and palliative care. Our first speaker tonight is going to be Melinda Cree-Anthony. She's the staff chaplain and in charge of spiritual care services with UnityPoint Health. And then we have Deborah Slaikeu, who's with Hospice for UnityPoint. And with that brief introduction, I'll ask Melinda to start. And also, if you would add to your resume, Melinda, the parts that I left out and give us some of your relevant history, that would be great.
Okay, thank you. First of all, I'm not in charge of spiritual care services, so I'll start there. I'm one of 8 chaplains with UnityPoint Health, and we have 4 chaplains at Iowa Methodist Medical Center, plus a director, and then we have 2 chaplains at Iowa Lutheran Hospital and 1 chaplain at Methodist West. Blank Children's Hospital is also included in our campus with Iowa Methodist, and we do have a pediatric palliative care program called SHINE. I'm not going to be addressing that, but I just wanted you to know that it is there. I've been a hospital chaplain 22 years in the Des Moines area. And I've been at I was at Broadlawns Medical Center for 12 years, now at Iowa Methodist Medical Center, 10.5 years. And then working with the palliative care team the last probably 3.5 to 4 years. So my duties are not only meeting with the palliative care team in the mornings as we go over the list of consults that have been received from the doctors and medical providers throughout the hospital on patients that they would like a consultation with. So it's important to know that palliative care is a consultation, and that, I'm setting my timer now, sorry, and forgot to do that. It's a consultation and supplementing your regular providers. So that's an important piece, and I'll talk a little bit more about that. My other duties with spiritual care services include sharing the on-call responsibilities at the Iowa Methodist Medical Center. My office is on Yonker 1 there, and with the other chaplains, we respond at all the campuses. We respond to traumas and deaths. We respond to stroke or cardiac alerts, and we also respond to requests that might be there. So we have some chaplains at Iowa Lutheran Hospital that provide groups for chemical dependency and behavioral health units as well. Yesterday, well, just a minute about me. And my background is United Methodist, and I did my training as a hospital chaplain at Iowa Methodist Medical Center from 93 to 95. Yesterday, we administered ashes for Ash Wednesday in the chapel by request. It was kind of a walkthrough. We did not have the usual service that we have. And one of my colleagues found these lyrics from the song Awake My Soul by Mumford and Sons, which seemed like a fitting alternative to the regular words used in administering ashes. In these bodies we will live, in these bodies we will die. Where you invest your love, you invest your life. So I want to say congratulations to you at St. Paul's Episcopal Cathedral and Church congregation on your series that you're having about end of life preparation. I think that's awesome. And so I listened to the first one on spiritual preparation for death, and it was very good. It was excellent. So I'm really impressed with that. and did meet Father Zeb Traylor when he was one of our resident chaplains as well, and was able to work with him. You are gathering valuable information on how to prepare yourself and your family for unexpected life changes that can occur at any age. Being hospitalized, having a new diagnosis, living with chronic illness are all significant life events that can impact many other aspects of your life and family. Your beliefs and spiritual practices will provide a foundation that will be a source of comfort, of strength and meaning and hope, and can make a big difference when these things do occur. Your legal and financial preparations, conversations with loved ones and trusted friends will also ease the transitions and changes you may experience with chronic illness. Of course, chronic illness is another step in that journey of caring for our health that we may not anticipate is going to happen, and it can happen at any age. Living with an illness or disease that's diagnosed that you'll be living with the rest of your life. It's not something that is usually reversible, and in most cases there is ongoing changes and decline that will occur, and yet at the same time you're wanting to and doing your best to manage the symptoms and to continue to live your life as fully as possible. So that's really important to know that the palliative care team, and I'm going to say more about what palliative care team, that's their role, is to help you to be able to live your life to the fullest and to be able to accomplish your goals given where you are at any particular point in time, at any point along the illness, from the time you're diagnosed to later as you have more complications or you have more concerns or side effects or symptoms. But one thing to remember is we will never know in advance how exactly we will feel or what obstacles or challenges or opportunities we will encounter. It's important to remember that a diagnosis is not the sum of your life, your identity, or your being. Strength of character, humor, wisdom, and insight, the ability to tell the stories of your life will be helpful too. And being becomes more important than doing. I'd like to share this from the book To Bless the Space Between Us by John O'Donohue. And he's got many other wonderful things, but I found this one, which is a poem or a blessing, but called For a Friend on the Arrival of Illness. And it's a little bit long, but I'm going to share it with you. Now is the time of dark invitation beyond a frontier you did not expect. Abruptly, your old life seems distant. You barely noticed how each day opened a path through fields never questioned, yet expected deep down to hold treasure. Now your time on earth becomes a full threat. Before your eyes, your future shrinks. You live absorbed in the day-to-day, so continuous with everything around you that you could forget that you were separate. Now this dark companion has come between you. Distances have opened in your eyes. You feel that against your will, a stranger has married your heart. Nothing before has made you feel so isolated and lost. When the reverberations of shock subside in you, may grace come to restore you to balance. May it shape a new space in your heart, to embrace this illness as a teacher who has come to open your life to new worlds. May you find in yourself a courageous hospitality toward what is difficult, painful, and unknown. May you learn to use this illness as a lantern to illuminate the new qualities that will emerge in you. May the fragile harvesting of this slow light help to release this slow light, help to release whatever has become false in you. May you trust this light to clear a path through all the fog of old unease and anxiety, until you feel arising within you a tranquility profound enough to calm the storm to stillness. May you find the wisdom to listen to your illness. Ask it why it came, why it chose your friendship, where it wants to take you, what it wants you to know, what quality of space it wants to create in you, what you need to learn to become more fully yourself, that your presence may shine in the world. May you keep faith with your body, learning to see it as a holy sanctuary, which can bring this night wound gradually toward the healing and freedom of dawn. May you be granted the courage and vision to work through passivity and self-pity, to see the beauty you can harvest from the riches of this dark invitation. May you learn to receive it graciously and promise to learn swiftly, that it may leave you newborn, willing to dedicate your time to birth. I found that to be powerful and I felt that it captured so much of what sometimes cannot be expressed or put into words. I'd like to define palliative care, and this is from getpalliativecare.org. Palliative care is a specialized medical care for people living with a serious illness. This type of care is focused on providing relief from the symptoms and stress of the illness. The goal is to improve quality of life for both the patient and the family. Palliative care is provided by a specially trained team of doctors, nurses, and other specialists who work together with a patient's other doctors to provide an extra layer of support. Palliative care is based on the needs of the patient, not the patient's prognosis. It is appropriate at any age and at any stage in a serious illness. It can be provided along with curative treatment. And they had a video saying you are a bridge, and they showed the person in the middle of the bridge, and that with all of the added demands and needs from a chronic or serious illness, that we need to be able to shore up and add an extra layer of strength to our bridge, basically. And that's what we do with our healthcare team, our families, the people in our lives, and the treatment that's available. There are so many chronic or serious illnesses that may be helped by palliative care consultation. And I'm only going to list a few. There are many, many more. Some of those include cancer, dementia, heart disease, also congestive heart failure, kidney disease, liver disease, lung disease. For example, my husband, Chuck, who died in July of 2015, had hypertension from the time he was 14, I think. So he was really young when he had that. He also then developed diabetes, arthritis, heart disease, had open heart surgery, and had congestive heart failure. He had chronic back pain, as well as he was a farmer, so from lifting a frozen hay bale, he ended up with injured back in his 20s, I think, and had some back surgeries, and he had declining kidney function. And that's all that I can remember. There might have been something more. So I'm going to reference Chuck, and my experience with Chuck informs some of my personal experience, but also my mother, Esther Lees, who died a little over a year ago on December 14th of 2019. My mother had dementia, osteoporosis, arthritis, anxiety, and chronic skin conditions like psoriasis. So I was her medical power of attorney. I'm the oldest of 5 daughters, and there's a stepson. And I was also her trustee for her trust. So basically, I did everything in consultation with my sisters, and with my husband, I consulted with his daughters at the end, near the end of his life as well. So both my mother, Esther, and my husband, Chuck, had multiple specialists. Because I worked with the palliative care team, I requested the palliative care team when they were hospitalized, or actually Chuck had palliative care come to our home, and we loved the nurse practitioner who came, and we're really disappointed that palliative care couldn't provide all our care, but that's not the case. Their consultation. And with my mother, we had palliative care, and they visited her in her memory care unit, and when she was in the hospital, provided valuable insight and processing for my sisters who were present there, and for myself, but also very helpful to my sisters as we talked about what was treatable, what was not treatable, what would be helpful, what would not be helpful, and so forth. In each, a palliative care team can be consulted, as I said, at any point along a diagnosis, and it can be done both outpatient and inpatient. Our outpatient team includes nurse practitioners and social worker, and then we have, they can reach out and work with your providers that you have as who are providing your care and treatment while you're at home. The team in the hospital for inpatient includes a physician or medical director, nurse practitioners, nurses, myself as a chaplain, but also we have available other chaplains for spiritual care. When you're at home, where you may be relying more on your own faith community leaders as well for spiritual care. And sometimes we help people reach out to someone or make a connection if they've kind of lost touch and don't have that faith community. So the team collaborates with the rest of your medical team, and that can include people like the social worker, physical and occupational and speech therapists, dietitians, and of course your doctors. Now, one of the tricky parts is that every member of your medical team might be evaluating and making recommendations about specific parts of your health and care needs. And the palliative care, I believe, team is going to look at the big picture. But beyond that, they're also going to focus in on what your goals are and be asking about what gives meaning and purpose to your life. What is it you want to accomplish? What are your worries and concerns? That includes your family's concerns, as well as financial concerns or mobility, all kinds of things that could include a list of things that I'm going to mention in a minute, which are symptoms that you may be experiencing. They want to help you live the best quality of life you can. To palliate means to cover or lessen the impact of something. So the team wants to get to know you, which is more than your diagnosis and your symptoms even. Who are your people? What are your hobbies? What are the things that are causing you suffering and distress? And that may include emotional and spiritual distress and suffering, not just physical pain. In fact, many times we need to address all of those things that could cause suffering. It could be broken relationships. It could be the pain, chronic pain, but it can also be mental health concerns, depression, all sorts of things. They help to answer questions you and your family may have, such as what are my goals for my care, and that's going to change. So when you complete advanced directives or have these conversations with your family, people often have the tendency of saying, well, I want this done for this amount of time. And the reality is, once a medical crisis occurs, if you call for an ambulance and so forth, then you're going to want to see, and your medical providers may want to see how well can you respond. And so you begin a process of finding out. On the other hand, you can have care at home, as Deborah's going to talk about with hospice care, and she'll explain that. So that would be the next step. would be when you're ready to give up coming back to the hospital, or having having to come back more frequently may be an indicator. And there are other things she'll talk about as well. When the other concerns might be, what do I want at this time in my life, knowing I have these medical conditions or these limitations, but what are my opportunities? Where am I going to focus my attention? And that's a spiritual practice. Where do we focus our attention, and what is the intention that we want for the time that we have? Another thing is to consider, is this treatment plan too burdensome for me or my family? So that's acknowledging the reality that and can be often a concern expressed that people don't want to be a burden to their family, but on the other hand, the family wants to be there for them, and so everybody's worried about everybody else. So the symptoms that they may make recommendations about would include anxiety, depression, fatigue, loss of appetite, pain, nausea, shortness of breath. And they'll ask about your future health needs and documenting your healthcare wishes. So if you've watched the second part of this series about your legal documents, and you've completed them, know that especially those advanced directives and durable power of attorney for healthcare, medical power of attorney, can be updated or changed. And sometimes they need to be because of changes that may occur in your family or relationships, or simply a person may not be available. So it's really helpful to have those things in place at any age, to have those in place. There's also available a checklist of different situations and kinds of life-sustaining measures to indicate what you would want. And that can be helpful in talking it through as well with loved ones. I felt very fortunate that my husband Chuck and I updated our wills and legal documents and advanced directives in the spring before he died in July 26th of 2015. I also used the conversationproject.org, which had a list of questions that I asked Chuck on my own. I hadn't heard about it and I looked it up. So I was able to go through the questions. And one of the questions was, is there anything you feel that your family and your doctors don't understand or don't realize? And Chuck said that he didn't think that they really understood how bad his pain was. And he was taking a lot of pain medicine. So that he felt that they didn't really understand that. But it could be other things too that maybe haven't been spoken about or haven't been brought into the open. So these are all, as well as code status, that was a part of the conversations we had, whether or not to have CPR. And we had talked in advance about whether we would want hospice care, so that when it came time and I could see that was drawing close.
Alert from calendar. CW Smith Concrete.
Hopefully you didn't hear that. I bet you did. It's my calendar speaking to me. So those are the kinds. I was gonna go back here a minute and excuse me for getting on the sidetrack a little bit. So those are all parts of crucial conversations that we can have before a crisis occurs. But at the same time, we don't know how we're going to feel when we get into a crisis, when we get there. So we may have an idea of what we would want, and our wishes can change. So, and circumstances can change. So those are kind of important to identify our values and our beliefs as well. And to know that it's important to reach out for spiritual care from your faith community or from the hospital chaplain. I like the term being called being a story catcher. There's many things I may listen for and ask for, including what gives you strength, who are the important people in your life, what gives you joy, Or well, are you suffering or in distress? What would you like the healthcare team to know about you? Sometimes I'll ask. Is there something, some of these questions I've already asked. So know that we're available for spiritual care in the hospital, and as well as your family and faith community. And I encourage you to reach out to those, reach out to your family, but also to consider recording your life story and creating a legacy and having those conversations. So thank you for this time, and I'm going to turn it over to Deborah.
Right. Thank you. It's always nice to listen to other points of view. There's a lot of different people out there across the healthcare spectrum, so that's always helpful and interesting to listen to others. My name is Debbie, and I'm one of the admit nurses with UnityPoint Hospice. The things that I'm going to be talking about are pretty much universal with any hospice. So we just want to get the word out there that hospice is there to care for the patient and the family. And what I'll do is just go over a little bit of what I've done to come to this point in my time, or point in my life. And I've kind of gone from one end to the other. At one point, I worked newborn intensive care, adult cardiac. I have done public health, education, visiting nurse services. I've done home infusion. And then I have been with home hospice now for almost 20 years. So this is kind of where I live, and this is my comfort. But I think I had to work in those other places to know that this is where I wanted to end up. So before I did hospice, I was, again, doing home infusion, and before that, the public health, home health. So I've really been doing nursing in the community for quite some time. And I like it because you really do see the patients and families where they are and where they live. And it's a little bit different from hospital nursing or anything like that, but it's something that always keeps us on our toes. We always say if we haven't learned something each day, then we're not paying attention. And when we talk about hospice, I usually, with an open group, I ask people how many times or have you had any experience with hospice? A lot of people equate hospice with the last couple of weeks of life. And that is the one thing that we're really trying to get out into the community and everywhere, that it is not necessarily the last couple of weeks of life. To be eligible for hospice, you need to have what the doctors can figure for the best part, a 6-month prognosis or less. Way back when hospice started and Medicare was covering it, you had 6 months. If you were not deceased by that time, your benefits were cut off. Surprisingly, Congress and the people higher up have figured out that, yeah, not everybody follows that program. So we have got a little bit of leniency there and a little bit of the real world. But what my one sentence definition of hospice is, we want the patient safe and comfortable, and we want the family educated and supported. And when we talk about hospice, it can take place in many different environments. So certainly we do home hospice. We also do hospice in nursing homes, and we also do hospice in group homes. So it can be across a wide spectrum. And we have done hospice in, sometimes in shelters, things like that. So we're pretty flexible. And again, when it talks about hospice, we want to focus on the patient and the family as a whole. So we walk into a patient's home and family, and we look at them physically, mentally, emotionally, spiritually, all of that. And all of that goes into what we want to do to help this patient and family. Everything that we do is guided by the patient and family. It's very much centered on them. And what we want to do is, sometimes with education and talking about it, things become less scary. So many people are afraid of hospice that, again, it's those last few weeks crisis. Whereas if we get a patient and family 3, even 6 months out, we have a lot of time to build that relationship, get to know them, get to know what's important to them. So then maybe when those changes do start, they've got people in their home that they know and they trust, and we know them, and that's our goal. But again, I think that is one thing that we want to work on so much, as hospice is just not the last week or so of life. And I'm to be following an outline that my supervisor gave me, and I have to look at my notes because I kind of go all over. I speak with my heart. So what we also talk about is hospice is not only for cancer patients. It's kind of what Melinda talked about. Cardiac, we have dementia, we have renal, or, kidney, liver, Parkinson's, ALS. All of those can be considered what we call a hospice diagnosis. And Medicare will cover 100% of home hospice services. And what that means is the team that goes into care for the family, any equipment that that patient and family may need, any supplies that they may need, and the medications that are related to their diagnosis and their comfort. And I go back up a little bit about that. So everybody, as the 3 core people involved in their team, is a nurse, a social worker, and a chaplain. I used to be a case manager who I would have a caseload and I would go see and, walk them through that journey. I transitioned to an admit nurse. So I am the one that goes out and sees the patient and family, does the evaluation, does a lot of education about what hospice is and what we can offer. Oftentimes we find that we go out and do a visit, people aren't ready for it, but they have that information. So then maybe when they are ready, they're like, okay, I know what hospice can do and what hospice can provide. So we love going out and doing those informational meetings. The other thing too is we kind of talk to them about, it's not just the last couple weeks of life. Hospice involves everything. So the nurse, of course, does a lot of nursey stuff. So we want to manage the symptoms. We want to talk about the disease progression, the disease process. And the other thing that is very nice too is we tell our patients and families that we have someone on call 24 hours a day. So if something happens at 2 in the morning, we've got a nurse that can come out at 2 in the morning. And we're all pretty comfortable with symptom management. So there's a lot that we have seen, and we had a lot of experience and guidance behind us to do that. We also have a social worker as an integral part of the team. They can also do a lot of education. They can do bridging with resources. It's like Melinda talked about as well. There are a lot of documents relating to end of life. We can't do anything with financial or legal property, but we can do the end of life medical power of attorney, wishes. I know that you guys had a program on that a couple weeks ago. So those are things that our social worker can help with as well. Again, do resources. We also have a program that's called Legacy and Last Wishes, where with some of our memorials, we put them in a fund where we can help people try and find something that will make it special for them. So I know that one time we had a teenager, and this is a while back, and this isn't my strong suit, but it was one of the many Star Wars movies that came out, and he really wanted to go to it. So we contacted the movie theater. They did a viewing just for he and his family. One of our staff nurses went with all the equipments. One of the ambulance companies donated their time. So those are the things that we like to do as well. The social worker often is one that will start that process, and then we just get input from everybody in the team. We also have a chaplain, and again, as Melinda had talked about, spirituality is such an important part to every patient and family. Some people have different faiths, they have different cultures, and just because they aren't necessarily in that, Christian framework, oftentimes our chaplains will go out and sometimes just speaking with them, bringing them comfort. The chaplains had a wonderful idea, because it's usually the nurse that goes out and attends the death when a patient does die. And they put together a list of prayers for us for many different faiths and cultures, so that we as the nurses could have that as our disposal if we had a death at 3 in the morning. So also they can be a liaison between the patient and family's spiritual connection in the community. So that is nice as well. And they individualize their care very much to each patient and family too. So those are what we call the 3 core members. We also have a medical director who oversees our whole program. UnityPoint Hospice, we are connected with Taylor House on the east side. Dr. Rebecca Lockemeyer is our medical director, and she's the one that oversees that as well. Also, as important to our teams is we have home hospice aides that can go into the home. They can help with personal bathing, they can do light housekeeping, they can do meal prep. We have a music therapist, a young woman with a beautiful voice. I can't sing. I'm very in awe of people that can, and a guitar. And she says, if I don't know a song, I will find it and I will know it by the time I come. And she just brings a lot of joy to many patients and families. We find that a lot of our dementia patients, Alzheimer's patients will respond to that music. We also have massage therapy. And the families always say, oh, can we have it too? We wish that we could. And a lot of times too, massage therapy may be just doing a hand massage, a foot massage, even the temples to get rid of a headache or a neck. So our massage therapists are very experienced with different needs that the patients have. It may not be pain. It may need to be for anxiety or relaxation. It can be for swelling in the arms or the legs, and they're very knowledgeable about that. Our volunteers are very important to us. COVID, of course, has really changed the face of a lot of things. Our volunteers can go and sit in the home with a patient so that the family members may need to go out and even something simple as get a haircut, run errands, or, pre-COVID, go out and meet friends or somebody for lunch. We also had pet therapy, which we're hoping to get going again. We have volunteers with their pets that have to go through a certification program, but we find that the pets are very much like little babies. It's often the people that have, again, the dementia, the Alzheimer's, that animal just brings a spark to their life. And we often see, a positive response. Maybe they haven't smiled in a while, or maybe they haven't laughed. Sometimes just the animal has that innate sense in them, and sometimes they just be with the patient. Maybe they sit there and the patient can put their hand on their head. And that's kind of the core team that compromises our hospice team right now, and it's individualized for every family. We talked about the supplies, so maybe hospital beds, wheelchairs, walkers, anything that can help that patient and family be safe and be comfortable. The other thing that we do is we try and look ahead. So maybe someone is getting very weak and tired. Maybe having a lightweight wheelchair that their family members can put in the car may mean that they can go to the park and, even if they have to stay on the sidewalks, at least they can get out of the house. So we always try and look at something simple like that. How can that maximize their enjoyment? We have what we call the bariatric beds, which are the larger beds. There have been times when there's been family members that, cuddling or being with their loved one is very important to them. We'll send one of our bariatric beds out there, and then that way the loved one, the family member, can actually get in the bed and cuddle with the person, and that touch can be so important. Any supplies that the patient and family might need. Sometimes if people have ostomies, we certainly would cover that. Catheters, wound dressings, incontinence products. So Medicare is saying, we're taking care of that patient and family. So those are the things that we cover. And then also the medications that are related to their diagnosis and comfort. So sometimes they go in and they change a lot of medications. Our practice is if, that medication is making them feel better, let's go ahead and do it if that's what they want to do. Some of our congestive heart people, we're not going to stop their blood pressure medicine or their diuretic. That's important to make them feel good. So we're going to leave that there. Some people are ready to let go of all that. And, we can help guide them through that as well. Oftentimes we look at supplements, vitamins, cholesterol meds sometimes at this point. So sometimes we can decrease that pill burden. So that's kind of what Medicare covers in a short little bit. We have a few different programs. Melinda had talked about the Shine program with Blank Hospital, and we do have a nurse, chaplain, and social worker that specialize in our pediatric patients, and we've had anything from a little newborn up until 18 years of age. And again, that kid that really wanted to go see that Star Wars movie. We have done some, with infants and things like that. Maybe they wanted to have, a family portrait. We have done that. I know that one time there was a patient that had lived here for quite some time and really wanted to become a citizen before he died. We helped make that happen. We have done weddings at home. We've done weddings at Taylor House. Our chaplains also can help with funeral planning, and sometimes they actually do perform the funeral ceremonies as well. And let me just quick look at my notes and make sure that I haven't skipped anything. Again, we try and be very, very flexible. No patient and family is the same. So we want to do whatever we can to make them comfortable. So again, it deals with symptom management, the psychological, the emotional, the spiritual component, and sometimes the financial. Sometimes there's some resources that can help with finances. We certainly, education is very, very important to us. Lots of times, if people know what to expect or what is coming, it may not be quite as fearful for them. And oftentimes, one of our main things that we do is we listen. And Melinda, I love that phrase that you said, story catcher. I'm going to tuck that in my back pocket, and I will give you credit when I use it. But what an incredible phrase. I'm like, wow, I like that. So oftentimes what we do is listen. And sometimes when we have calls in the middle of the night, you find that just going out there and maybe sitting with the patient and family for 30 minutes is just what they need to calm down and to be more comfortable. We talked about that, hospice takes place in many different places. We do all ages from birth to death. We do have a program, and I know this is kind of a national program that's out there, and it's called Honor Veterans. So we lose so many of our veterans each day, especially the ones that have served in, World War II, the Korean, the Vietnam conflicts and all of that. But what we usually do is have the nurse, the social worker, the chaplain, and we invite family and family members, and we'll do just a small, what we call a pinning ceremony, but we talk a little bit about what their service has been, what it's meant to the family, and then they just have that little pin that they can wear, and then the family can keep it once that is done. And I think I'm getting towards the end and kind of wrapping things up. There is a program that we're one of, I think, 80 hospices across the nation that we're kind of trialing, and it's called Care Choices at Home. So it's kind of a step between palliative and hospice. And it's been going, I think, for 4 years, and they extended another year. So it's where the nurse, the social worker, and the chaplain can go out a little bit more often than what palliative can, but not quite as often as what hospice does. And then what we're hoping to do is find those, just guide those patients and families into hospice when the time is right. So that's the end of my little part of it.
I think at this point we can open it up to questions.
I just have a comment that story catcher is not a term I created. I borrowed it.
All right. Well, we will still share. It's just such a beautiful word. It's like,
and it's not mine.
Gosh. All right. But that's a keeper. And the participants that we do have, I would be interested to, know too. When you think of hospice, do you think it's that end of life, or do you think, oh, you know what, hospice can be involved before that?
Yes, I would have naturally thought of the last few weeks of life typically. So So thank you for educating me
Right.
today.
And that's part of what we do. And, you know, palliative too is a relatively new program. So that's something that we spread the word about too. Maybe they're not ready for hospice, but, you know, palliative might be right up their alley. They kind of merge and overlap a little bit.
Melinda, I had a question for you on palliative care. If you have someone with a chronic condition and they are sometimes repeatedly hospitalized, do you have to initiate palliative care team every time on hospitalization, or is it something that can be flagged in the chart?
Right. So that's a good question for the outpatient. The palliative care consult, you can request it, but it actually comes through the doctor. So the doctor makes the consult request. So it's sometimes we have patients who are coming back, and if there's no particular needs, then they don't automatically come into our list. We're responding and seeing the patients where there's a consult or a need for, and it could be that consult happens more than once because of changes that have occurred. So I would tell the doctor or the nurse of that request to get it and go in motion. Yeah.
So I have a question about your experience. You know, we live in a sort of a postmodern society, and, you know, I think about my own upbringing. You know, my father was in the medical profession. I'm a bit of a scientific mind. And, you know, initially in my earlier years, I really thought we could fix most things medically, you know, with pills and surgeries and all that sort of thing. And I've really moved in my position a lot in recent decades. And anyway, I could say more about that, but I won't. You know, my question is, you know, I wonder if you find there are people that you encounter, patients who really don't have the language to be able to articulate what they need in terms of spiritual, emotional needs, and how do you deal with that?
Melinda,
Yes.
do you want to go first?
I can. Yes. Cognitive change. First of all, it could be due to cognitive changes or dementia. When things are happening in the brain, it's harder for people to process, and sometimes they cover very well. So they might be able to engage in conversation. And the other piece is that we're all very different. So some people are going to be focused on and understanding their needs differently. And it got to start where people are at. That includes spiritual care needs, where people may be of a different faith traditions, but a person who has cognitive impairment or a disability, lives with a disability, is a good example. Then you look to see, in keeping them comfortable, what are the signs of distress? Are they agitated? Are they, you know, wrinkling their brow? Or are they restless and just trying to get comfortable in bed? Or you may talk to family members and find out more about them, and the family members may pick up on things as well and be able to share things that the person can't.
And I think you touched on it very well. We always call it the nonverbal. So people always worry if they can't speak, how do we know if they're comfortable or not? And it's exactly what Melinda said. One of the things we look for is a relaxed face and body. And if someone is comfortable, their body is going to be relaxed, their face is relaxed. If their face is scrunched up, they're tight, they're moaning, okay, we need to figure out what is making this patient uncomfortable. You know, and the cognitive too. Sometimes we look at, so what did this patient used to do? Is there things that we can do? We have things that are called busy blankets that our volunteers make that will have zippers and snaps and buttons. Lots of times if we give people a mixing bowl and a spatula, that kind of, oh, I used to do this. Some of the men, we look for some of the safer tools, not screwdrivers and hammers. We don't do that. But there's things too that people, we don't know what's going on in that mind, and we don't know what quality of life is to them. I had a ballerina one time, and I am not a dancer, but I did one of those little turns, and she laughed and pointed at me, and she got up and used her walker, and she started doing some of those dancing moves. So we really try and step back and look and see what drives this individual and what might be significant to them. Even if they're not in our world, what can we do to meet them in theirs and make that world safe and more comfortable for them?
Mm-hmm. So making eye contact, speaking directly to people, going where, letting them lead the conversation, for example, if they and people have very different comfort levels, and they have different insight and ability to put into words what they may not be able to have deep philosophical or theological conversations, and usually if you're in pain, that's pretty difficult to do, but they can talk about things that are meaningful to them usually. And if not, then it's just having that personal contact and knowing that somebody's there, and that attention and time with another person can make a lot of difference. So.
And we call that presence, and we will actually chart that often offered, presence to patient or family. And sometimes just sitting there. And again, we get to know each person. Everybody's different about touch, things like that. So if it's someone that, we set and we just hold their hands and they calm down, absolutely wonderful. There's been times when I've entered a room, I've seen that they have CDs over there, put the music on, and I may sit further away from the bed, but there's just a lot of things that we can do for those people that do have those cognitive changes. That again, make them an individual and make them comfortable.
Mm-hmm.
Oh, wonderful, thank you.
I also wanted to add that with palliative care, when a person is in the hospital and they're nearing the end of their life, they may have a nearing death awareness. They may have experiences that will, they may have dreams or see people who have died. They may be reaching out, or they, they just may have this awareness. They may talk about it, and it may sound confusing unless you think about that happening. And when a person is transitioned in the hospital to what you would have as hospice care at home, in the hospital, we'll call it comfort cares. I know we're still providing care, and it's to keep them comfortable. So for some reason, that's the terminology we use.
I think it's so much of what hospice and palliative is, it's so much more than just the physical, but one of the favorite things that has always been very meaningful to me is we always know that when a patient may talk about travel, it's time to go, where's the keys, we're going to be late. They may smile at somebody that we don't see. They may reach for someone. I don't want to put a whole lot out there, but my personal belief is that nobody changes worlds by themselves. Mm-hmm. And each time that we hear about that or take part of it, to me, is just very sacred and just absolutely amazing. Mm-hmm. So it's not anything that you can define easily, but it's those things, and those are the things that you have to be open for and watching for.
Are there other questions?
I think I have one more, which is more on the practical side. So you're speaking definitely in the Des Moines context. So is palliative care something that's really widely available these days to anybody?
It is more available. Yes, and it will differ some in some parts of the country. In some places, they will in fact be meeting as a team with you or with the family. So, and in our case, we're kind of doing things more individual. I'm kind of doing my own thing, but if I was needed or requested to be at a family meeting, so they would coordinate family meetings if needed, and be communicating with family. And yes, it should be, it may not be at every single hospital, but I would say in the larger metropolitan areas for sure. And I think the palliative care services has been growing, and now our department had grown over the last maybe 10 years or so, and now there's been kind of a cutting back due to financial constraints that's happening in healthcare. But I think you'd have to ask to find out, and it may be experienced differently or offered slightly differently in different places.
Thanks.
And we appreciate your time too, to be able to, I call it speaking my heart, to talk about hospice, and the same with Melinda.
Thank you, Deborah.
It's just wonderful to share a message. And again, we want to decrease that fear. We want to normalize things. We want to help the patients and families in whatever way we can.
Well, I want to thank you both for being available tonight. It's been very, very informative. It's very evident that you're passionate about your work, and I'm grateful that you are, because you do really vital work. So thank you both.
Thank you.
Thank you all. Have a good rest of the night.
Thanks,
Okay,
everyone.
healthy.
Okay.